afternoon. Welcome to this question and answer session sponsored by MS Focus, the Multiple Sclerosis Foundation. My name is Cherie Binns. I'm an MS certified nurse and I am the patient healthcare liaison for the foundation. I'm also an individual living with multiple sclerosis, so I can kind of see things from both sides of the desk. These Ask the MS Nurse sessions that we do several times a year are designed to give you the opportunity to ask questions about symptom management, the plan of care that has been maybe recommended for you, but maybe you've got questions about it. Um, if there are treatments or medications that you're considering, how you might best make those decisions. So feel free to bring your questions, tick them into the Q&A at the bottom of your screen. If you wish to ask a question personally, there's a raise hand button at the bottom of your screen if you're on Zoom. Just click that. If, however, you're calling in on your cell phone, you'll have to hit *9 to raise your hand. And what I will do is to go ahead and allow you to unmute. I see Karen already has her hand up. Karen, I'm going to allow you to talk if you want to unmute.
Thank you. I do. I'm asking not so much for advice about care, but information from your career in regards to your interpretation of MS progression. I become very confused with the buckets of relapsing remitting and primary progressive, and quite honestly, it almost seems cruel in a way because you're trying to buy, where am I? What? Oh no, this happened. No, no, then I'm over here. And it just seems to be extremely unclear. And I've been listening to some recent research information about how it's your DNA composition that dictates how the disease will progress once you have it, in addition to your, probability of getting it. And I just feel like
Yeah.
that sounds more true to me.
Okay. First, let me ask you, are you on a disease modifying therapy?
I am. I am.
Okay, good.
I'm on Kesimpta. My
Okay,
first symptoms happened at 61 and I turned 65 last week.
perfect.
Um,
Okay, progression, the idea of progression has changed drastically over the years. My first episode with MS was back in 1975, but I wasn't officially diagnosed until 1994 when the first medicines came on the market.
mhm.
And at that point, they were saying that within 10 years of diagnosis, you would, about 50% of us would likely need a wheelchair. Now that we have a 30-year window of looking at the impact of our MS medications um, on the disease course, we're seeing that people are not converting to secondary progressive after 10 years, and some of them after 25 years have still not converted. So getting that medication on board is essential to helping to manage that disease progression. Um, I think those people that are being diagnosed early now and getting onto particularly a high efficacy medicine similar to what you're on um, are probably not going to see any progression at all. I mean, if they get sick, um, they may, particularly if it's I'm not talking just a simple virus or something of that nature, but if there's a severe illness or injury that sidelines them, that may trigger a little bit of progression. But likely that's going to be well managed. So, I think if you're on Kesimpta now and you're able to stay on a high efficacy medication like that over time, I think your chance of being sidelined by progression are very minimal. You're likely to live a full lifespan, comparable to your peers without MS.
Wow. Yeah, I feel that. So thank you for
You're
validating.
so welcome. I'll ask you to mute again so we can take other questions.
Yes.
Thank you. Let's see. An anonymous attendee says, from my first MS event, which was optic neuritis, to my first rituximab infusion was 3 months. Could steroids have been used to calm my symptoms before my first infusion? They could have been, but we now know that steroids make virtually no difference whatsoever in the outcome. They just the difference with people that are getting steroids to manage their flares or the angry symptoms between infusions or before they get started on a medication is that those individuals tend down the road 5-10 years from now, from the time that they got the steroids, are going to start to have several other health issues that are going to make the MS more difficult to manage in the long run. So things like hypertension, high blood pressure, obesity, weight gain is a big problem with those that get steroids with any kind of a regular basis. And of course, that does tend to increase your high blood pressure. Um, Both the obesity and the high blood pressure can lead to cardiac disease. Diabetes is another one that steroids is directly contributing to. And we're now seeing thyroid disease as something that the steroids are contributing to. So I don't recommend steroids for the most part, but once, before somebody is on a medication, it might be very helpful just to calm things down a little bit with the steroids. The steroids will stay in your system for 1 to 2 months. So it might have been helpful, but in hindsight, I'm not certain that we can do too much about that. Another anonymous attendee says, I recently had a visit with my neurologist, and when she did the reflex test on my knees, they didn't react. What does that mean? It could mean any number of things. It could mean that she wasn't testing you absolutely correctly. There's a very specific point that you need to hit with the reflex hammer in order to get your leg to respond properly. So that's a question that it could very well be all in the way the provider did the test. I don't think it's anything major, or she would have said something about it. Gus says, can you talk about the long-term safety and efficacy and the risk of cancer with Mavenclad? Thanks for that question, Gus. Mavenclad, or cladribine, as its generic is called, has been in use now for about 30, about 30 years. It started off being regularly used in the UK, and it was approved here for MS in 2018, 2019, right around then. But before that, we were using it to treat cancer. So it's quite safe. We see very, very little cancers in the dosage and frequency that we're using it in. Um, Another thing that I'm seeing more and more frequently is those of us that are aging with MS and are getting to a point where our immune system may be slowing down naturally as we hit 60 or over 60, um, may be a candidate for Mavenclad as what is now being termed an exit therapy. Um, Cladribine or Mavenclad is given 2 weeks, for 2 weeks. It's a pill that you take 5 days the first week and 4 days the second week, and then you repeat that a year later. And it seems to reset the immune system so that you're not having relapses anymore. And a study came out a couple of weeks ago looking retrospectively, looking back at people who had gotten their doses of Mavenclad or cladribine 15 years ago and still had no new disease activity, no changes on their MRI, and no disease progression. So it seems to be very safe in the long term. Okay, thank you, Gus. Another anonymous attendee says, is ataxia a form of MS? No, it is not. Ataxia may be a symptom with MS, but it's not a form of MS. Let's see. Danielle, can you explain how menopause or premenopause affects women with MS? It definitely seems to make the symptoms a little bit worse. We know, and we've known for years, that prior to our menstrual cycle, our PMS tends to be a little more aggressive, maybe, than somebody that doesn't have MS, and it seems to impact our symptoms, particularly the heat-related symptoms. So weakness, visual disturbances, extreme fatigue, uh, cognitive fog, all of those things tend to be a little bit worse when temperature is elevated, as it often is just prior to the start of a period, or with hormonal shifts. So you're going to see these things become a little bit more dominant. Um, and they tend to be episodic. So it's now thought that it is um, not a bad thing to have the conversation with your primary care doctor or with your gynecologist about maybe starting on some hormone replacement therapy to kind of manage some of those menopause symptoms so that they're not negatively impacting your MS symptoms. An anonymous attendee says, is there anything I can do to prevent blue color and bruising from lab tests for MS? Keeping pressure on the puncture site for a couple of minutes after being stuck, after the needle has been taken out, can help with that. That is not related to MS at all. It's totally related to the technique of getting the blood sample and to your specific bruisability. If you take aspirin or ibuprofen on a regular basis, that may be causing you to thin your blood a little bit more, so you may be more prone to bruising. Kimberly says, are there any disease-modifying therapies or meds that will actually help secondary progressive? I'm in a wheelchair for 2 years now and starting to feel pretty hopeless. Siponimod, which is Mayzent, is the only medication that we have currently on the market specifically for secondary progressive MS. That said, a lot of our doctors are using medications like Rituxan, which is almost identical to Ocrevus. Ocrevus was approved for primary progressive MS and relapsing forms of MS. So technically, your insurance is probably not going to approve Ocrevus for you if you're definitely secondary progressive, unless you have active disease going on. You may be progressing, but your MRI is showing new lesions. And frankly, you are at risk for showing those new lesions and having a more active form of disease, even if you are secondary progressive. So it behooves you to have that conversation with your doctor and see if there isn't something that you can do to sort of slow that. As to being in a wheelchair for the last couple of years, no medication is going to get you out of that wheelchair. The only thing that's going to give you a little bit more mobility is a commitment to regular movement. And you can do regular movement from your wheelchair. There are a number of different chair exercise programs that are online right now. In fact, the MS Foundation does sponsor one on a regular basis every week. And those exercises can all be done while you're seated in your chair. And they improve your muscle tone, they strengthen your core, and they reduce the risk of falls or further progression of disease. So exercise is definitely something that you need to be incorporating if you want to be improving that mobility. But I think having that conversation with your doctor about getting onto a disease modifying therapy might be very helpful. Gregory says, at what age is disease modifying drugs no longer effective? I'm 55 and on a DMD. There was a recent study that was done over a 3-year period looking at about nearly 400 individuals that were on a disease modifying therapy and 400 the same number of individuals that were willing to go off their disease modifying therapy and then following them over a 3-year period. All of these individuals were on older injectable drugs that aren't as effective as most of the drugs that most of us are on today. They were with the interferons and with Copaxone. So drugs like Betaseron, Avonex, Rebif, and Copaxone were the drugs that were looked at in that study. In order to qualify to be in the study, you had to have had no MRI changes in the last 5 years, and you had to have no disease progression, no change significantly in what they call your EDSS scale, which is your disability scale, looks at walking predominantly. And what they found at the end of 3 years was that 32% of individuals that stayed on their medications did have some relapse activity, and 33% of those that went off of their medications had relapses. So it was almost statistically the same. A new study came out about a week ago looking at specifically the more higher efficacy medications, fingolimod or Gilenya, and natalizumab or Tysabri. So it looked at those two medications specifically and found that people that came off of them as they aged had a far higher incidence of relapses than those that were on the lower efficacy medications, meaning that those persons may have actually had a far milder course of the disease as well. They found that people that were on Ocrevus, Rituxan, I don't know if they looked at Kesimpta or Briumvi or not, did not have as likely a chance to relapse as those that were on Gilenya or Tysabri. And I think part of that is because the drugs Gilenya and Tysabri are out of your system relatively quickly once you've had your last dose of it, whereas the B cell depletion medications like Ocrevus or Rituxan or Kesimpta or Briumvi tend to sort of suppress that level of cells that trigger inflammatory processes to happen for a very long time, generally a year or longer. So those two particular drugs were the ones that were most impactful. Elaine from Facebook asks, do you know of any programs that help with cost of brand Copaxone? Yes, Shared Solutions, which is the patient program at Teva Pharmaceuticals that make Copaxone, have a program for those that are uninsured or underinsured that need to be on that drug. Many insurance companies are no longer paying for name brand. They're only paying for the Glatopa, which is the generic form of the Copaxone. And a few people find that they're getting better results and better tolerance with the brand name than they are with the generic. So I would just Google Shared Solutions, or maybe Bhavya can look up that number on the web. It's a toll-free number, and tick it into the chat and we'll get that information for you. Thanks, Elaine. An anonymous attendee says, does it make a difference when I get my MRIs? I'm getting my brain and thoracic spine MRIs a month after my next infusion. It makes no difference whatsoever. Your MRIs really don't, they're not time sensitive as far as infusions are concerned. So you can get them anytime. Now, while we're waiting for more questions to come in, something big in MS treatment or in protection, not necessarily MS treatment, came down the pike last week. The FDA gave emergency use authorization approval to a new drug for those of us that don't mount a good vaccine response or even maintain antibodies after getting infected with COVID because of the medications that we're on. And those are predominantly the B cell depletion medications like Ocrevus, Briumvi, Kesimpta, and Rituxan. There is now a new medication called Pemgarda. That is the trade name of the drug, Pemgarda, and it has just been approved to be given to persons who are immunocompromised and don't mount a good response. It can be given up to every 3 months in order to keep somebody from contracting COVID. Now, you cannot get it if you've been exposed to COVID. You can't get it if you have just had COVID, and you need to wait at least 2 weeks after a COVID vaccine before getting it. It is a 1-hour infusion that's given in the healthcare setting, and then they do keep you for a couple of hours of observation afterwards. I guess there are a number of individuals in the clinical trials of it that had some itching afterwards. So, and that could happen as long as an hour or so after the infusion. So they kind of like to keep an eye on you so that they can give you something to help that if that happens. An anonymous attendee asks, is there any assistance for teriflunomide or Aubagio? Aubagio also has a drug program where they'll give you free drug if necessary. But the beauty about teriflunomide is that Mark Cuban's Cost Plus now has it for about $14 a month. And so most of us have copays that are way higher than that, and you get your entire month's supply for that price. So go to Mark Cuban's Cost Plus on the web, and they have both the 7 milligram and the 14 milligram dosing on that. But if you are on Aubagio itself, the drug company does have a program to help with that. Another anonymous attendee says, is slight lesion growth a sign my DMT isn't working? It's not so much lesion growth as it is whether or not the lesion activates with contrast. If you're getting an enhancing lesion when you have the contrast with the MRI, that is a sign that your disease modifying therapy is not working and may need to be changed. But lesion size really isn't. It could just be a matter of positioning in the MRI machine. An anonymous attendee said, I was on Rituxan for 2 years and then relapsed and was changed to Tysabri for about a year. I think about changing to Ocrevus. What are your feelings on that? You can certainly change to Ocrevus from Tysabri, or you could go back to Rituxan. The two drugs are basically identical drugs. So my guess is that you're more likely actually to have a little better control with the Rituxan, because Rituxan can be dosed differently if need be to prevent relapses than Ocrevus can. Ocrevus, you kind of have to stick with that every 6-month dosing, although now they're allowing prescribers to dose a couple of weeks early, so that if you hit that crap gap where you feel worse for a couple of weeks before your infusion, that giving it early may help with that. Whereas Rituxan can be given as often as every 3 months at lower doses to just keep your blood levels even, so you're less likely to relapse or have symptoms. So it's entirely up to you as far as what you do. I don't know if you're not happy with the Tysabri. It's a very, very good drug, and most people really like that. Or if it's that your JC virus titer is beginning to increase and you need to think about getting off of it and onto another drug. But Rituxan or Ocrevus would be fine to go back to if your doctor agrees with that. Kimberly says, why do you think the two most devastating exacerbations I've had have been when I've had a fever? The first put me on a walker, and the second in a wheelchair, and I lost my bladder. Infections don't actually cause relapses. They can, however, worsen our MS symptoms, and it can, if you've not had any evidence on an MRI that you've had a relapse, if there's no new MRI evidence whatsoever, the progression that you're talking about is related to the infection itself. So I'm sorry that that's happened. Now, on a personal note, after my last bout with COVID, I had COVID in August of 2022, and then in October of 2022, I got another vaccine and also a dose of Evusheld, which the Pemgarda that I just mentioned is the first drug that's come back to market to sort of give us help fighting COVID. And then I got COVID again in December of 2022 and developed long COVID. And I really felt like my MS was progressing and I was going downhill. My neurologist, after 6 months of these worsening symptoms being there, started me on monthly infusions of intravenous immunoglobulin, also known as IVIG. And within 4 or 5 months, almost all of the ramifications of that long COVID lifted completely. So that may be a conversation you might want to have with your doctor as well. Does it make sense to give me a trial of IVIG to see if I can't help to reverse some of these infection-related changes that have caused progression? But again, I can't emphasize enough the need to be moving on a regular basis in order for that to be effective. Mark from Facebook says, is B-cell therapy safe? Ocrevus. Yes, B-cell therapy is very safe for the majority of us. There really isn't anybody that we're targeting right now that we can say, if you've got this going on, don't take this class of medications. It is the most effective class of medications that we currently have to treat MS and to prevent progression of disease. So yes. Angie from Facebook asks, I'm newly diagnosed and seeing that the heat makes the MS worse. Is this true? Heat does make our symptoms worse. It doesn't make the MS worse. It has no impact on the course of the disease, but it makes the symptoms feel worse. As far as heat is concerned, the MS Foundation, MS Focus, does a cooling program from February 1st to June 1st, every single year, where we give away free cooling vests or cooling accessories such as collars, hats, wrist and ankle wraps. And so that program is currently ongoing. If you go to msfocus.org and click on the Grants and Programs tab, and then scroll through till you find cooling program, there is an application on that site for the cooling program. We do need just a letter from your doctor stating that you do have MS, and there's a one-page application for you to fill out as well. And you'll be able to get that those cooling supplies in the mail within generally a couple or 3 weeks after you fill out that application. If you do have trouble filling out the application, just call our phone number, which is 888-673-6287, and somebody can help you fill that application out online. Let's see here. I have a hand raised. Karen has her hand raised again. Go ahead, Karen, and unmute. And
Thank you. Back with another question regarding PEMGARDA that I was not aware of. This then prevents severity of the COVID should you get it. Is that correct? Or prevents you from getting it?
No, PEMGARDA is taken prophylactically so that you do not get COVID. It is not to be done in lieu of a vaccine. You need to be getting your vaccines regularly, but it's only for people who do not mount a response to the vaccine.
Okay, I see. So it gives your body a chance to mount
Right.
so you should get it before you get your booster?
No, no,
Oh,
no, you get it
sorry.
2 weeks after a booster.
Okay.
And it's pretty much only for those people who are really immunocompromised. And with our MS medications, the only medications that severely compromise us with our immune system and make it difficult for us to mount a good vaccine response are Ocrevus, Rituxan, Kesimpta, and Briumvi.
I understand. And
Okay.
okay, thank you. Thank you. Thank you.
Thanks, Karen. If you could mute yourself again, please, I would appreciate that. Cindy from Facebook asks, let's see, why do I feel more fatigued before I receive my next Tysabri infusion? Again, that is what we like to call the crap gap. And you're going to be needing to probably talk to your doctor about the possibility of maybe doing it 2 or 3 days earlier, just to kind of get you over that hump. Some doctors are willing to be a little bit flexible in the dosing of that. That said, we're seeing more and more people also, that particularly people that are JC virus positive, where their numbers are beginning to trend up. They're beginning to extend the intervals between dosing for that. And if you're feeling worse during that time, it may be time to have the conversation with your doctor about switching to a different medication and seeing if we can't get away from that crap gap by taking um, something that's, a middle efficacy drug, such as maybe Gilenya or um, Tecfidera, or by going on to one of the B cell depleters, which is a higher efficacy med that doesn't necessarily have that crap gap to deal with. Let's see, I'm going to, Karen, can you, let's see, lower, I'm lowering your hand. Okay. I just had noticed that your hand was still raised, but I can lower it. An anonymous attendee asks, do you have any suggestions for a fatigue medication? Provigil isn't helping any longer. Provigil will stop working if you take it every day. Fatigue medicines are not to be taken every day. Although many people do take them every day, they lose their efficacy over time. Provigil's pretty much the top of the line for the fatigue medicines. Now, one of the things that we really have some pretty solid evidence of right now is that regular movement, regular exercise reduces the intensity of fatigue. So I know when you're really fatigued, you don't feel like you can exercise, but there are some low impact exercises, things like stretches, things like low impact aerobics that actually do help your fatigue over time. Now we had one of our physical therapists on last Thursday, and he did a wonderful talk on the impact of movement on MS symptoms. That is on our main public Facebook page, and it should be up on YouTube probably within the next couple or 3 days. I would say by the end of the week, it should be over on YouTube. And he gave a host of different exercises that are very helpful for people for whom fatigue is the worst of their symptoms. Another anonymous attendee asks, how is Rituxan given? Infusion, shot, etc., and how long does it stay in the system? Rituxan is generally given every 6 months by infusion. Within the first 2 to 3 days after you get your Rituxan, it does suppress the CD19-20 lymphocytes, which are targeting inflammation in your central nervous system. So it's relatively fast acting, and it keeps those cells suppressed for 6 months to a year. We routinely do the infusions every 6 months, but with Rituxan, again, as I had said before, you do get quite a flexibility in the dosing schedule and can work with your doctor on a pretty regular basis, if need be, to change both the dose and the frequency of the Rituxan. Generally, you're getting 1 gram of Rituxan each infusion that you're getting. However, just prior to the pandemic, some MS researchers in Spain published a paper looking at the efficacy of Rituxan at lower doses, and they discovered that people that were getting as little as 500 milligrams every 6 months were not having any new disease activity. So you may not need quite as much with Rituxan as is often given as a standard dose. And that lower dose may be given if you get too suppressed. Now, with Rituxan, with Ocrevus, with Kesimpta, with Briumvi, you should be having blood work done, lymphocyte subsets, and immune globulin panels to see if you're getting too suppressed before you get your next dose. And that way, either the distance between your dosing can be increased, or the dose with Rituxan specifically can be lowered to something that's not at the 1,000 milligram or 1 gram level. Okay, I don't see any more questions in either the chat or from Facebook or in the Q&A. So if anybody has a question, you have my undivided attention at the moment. Aha, an anonymous attendee says, are there recommendations for pain management from MS? I'm taking 800 milligrams of ibuprofen and tizanidine. Those are exactly what we would have you do. Excuse me, I'm turning off my space heater. I'm here in New England, and we have high winds and temperatures just hovering above freezing right now. So my office is a little chilly. The ibuprofen and the tizanidine are helpful. The other thing, oftentimes MS pain is related to musculoskeletal pain. I see you're taking tizanidine, which is for spasticity. Spasticity is a major cause of pain. And so it's incumbent upon the individual who is having spasticity to get into a regimen of regularly stretching out those muscles that are so tight, and that can reduce the pain. And a physical therapist can target which stretches are going to work best for you and the frequency with which you might need to be doing those stretches. But the ibuprofen and the tizanidine are helpful. Another thing that you might want to run by your doctor is whether or not they think it's reasonable for you to, if the ibuprofen's not doing the job, to switch to Aleve every 12 hours instead of ibuprofen every 8. It tends to work slightly differently, so it may offer a slightly different form of relief. Anonymous attendee says, I have severe muscle spasms. I've tried baclofen, tizanidine, and carbazepine, sorry, but none of them have helped. My doctor thought I was having paroxysmal kinesiogenic dyskinesia from exercise. Not sure if he still thinks that. Are there other options? Thank you. No, those are the medications that we usually use for spasticity. But again, I can't stress how important it is, if you have spasticity, to be on a daily stretching regimen. The medications aren't going to do the whole thing. Stretching is going to help. Now, the other thing that you might want to have, if the spasticity is severe, another thing that you may want to talk to your doctor about is a baclofen pump. Now, a baclofen pump puts a very small dose of baclofen right into the spinal cord sac. And so it bathes the spinal cord, which is where the spasticity originates. With a small dose of medicine, it's small enough that it has a big impact, but it doesn't have the physical side effects that taking the oral baclofen have. So you're not going to be as hazy mentally or as fatigued. And the pump is inserted in a little flap under the skin of your abdomen, and it is filled every couple of months in a visit with the doctor's office. I believe there are a couple of companies that go around to your home now and actually refill the pump for you. And it's just a matter of injecting more medication into a little valve on the pump under your skin. An anonymous Let's see. An anonymous attendee says, how serious is the liver issue with the Baggio? Is it a low percentage of people that are affected? Um, it is relatively low, and it also can be managed with something like milk thistle, which is an over-the-counter supplement. Milk thistle is one of the few um, supplements. It's an herbal supplement that actually reduces inflammation in the liver and lowers the liver enzymes. And there have been several placebo-controlled trials on milk thistle, and those trials have, across the board, shown benefit with the actual milk thistle over the placebo in every trial. So if the Aubagio is doing what it needs to do for you, and your liver enzymes are going up, I would talk to your doctor about trying some milk thistle. You can take, according to the clinical trials, you can take up to 600 milligrams twice a day. That's the maximum, but it's usually in 75 milligram to 250 milligrams over the counter. Um, I know when I was on Avonex and on Rebif, my liver enzymes went way up and it brought them down almost immediately. The only side effects with the milk thistle are a little increase in gassiness and bloating. And some people do have some loose stools with them. And since so many of us have constipation, that may be a benefit for you. But do talk to the doctor about milk thistle and whether or not that might be something that could be helpful for you. Linda from Facebook asks, can MS cause tears in knee and shoulder joints? Not generally. That's not to say that if you have severe spasticity, it's not putting so much pressure on the muscles of of the joints that it could be causing some tears. So I would definitely talk to a physical therapist about that and see what they can do to mitigate that and to get you back on track for good healing. Jody from Facebook asks, once you have a symptom, are they always there? Like headaches, muscle weakness, fatigue, and and they get worse or feel worse after long days, etc. Also, my legs are extremely tired and I get cramps after walking a lot. Generally, the symptoms that we get with our first attack are the ones that will get worse when we're not feeling well or when we're overtired. Um, they can hang on. But again, a stretching program, an exercise program are key to keeping those symptoms manageable and at bay. An anonymous attendee says advice on pain relief for knee osteoarthritis. There are a number of different things with osteoarthritis. I would say if you know that it's osteoarthritis of your knee, if you're convinced of that, you don't just think it is, then you need to be seeing an orthopedist and get their recommendation on what to do about it. If it's severe osteoarthritis, then what they're probably going to be doing is recommending a knee replacement. As far as knee pain, something over the counter like ibuprofen is probably what they're going to recommend that you do. And they're probably going to recommend a range of motion exercises so that you'll be working with a physical therapist on that. Anonymous attendee asks, is there a generic for Rituxan? Do some insurance plans cover it? Rituxan is the generic. Rituxan has been on the market for probably 30 years. We were in clinical trials on Rituxan for MS back in the 90s and early 2000s. And then Ocrevus came on the market, made by the same company, basically the same formula. And when that happened and was approved for MS, the Rituxan trials stopped. They're extremely effective. They're about half the cost per dose of what Ocrevus is, and therefore almost all insurance companies do approve it. Melissa says, I recently started taking Simvastatin, 40 milligrams twice a day. Memantine. I also take Ampura and Donazepam. Is this combination too many chemicals? Take Ritux and other medications for other diagnosis. Melissa, I don't know what your underlying health conditions are. I don't know if these are things that you're taking because you heard about them and asked for them. But I'm finding that one of the best resources for questions like this is to go down to your CVS or your Walgreens or Rite Aid, or your private pharmacies, if you have one that you're utilizing, and talk to the pharmacist. They're very, very knowledgeable in interactions on your medications. And so I would bring those questions to a pharmacist as well as to your primary care and your neurologist when you see them. Linda from Facebook. Let's see, I've got a couple of questions from Linda. Oh, you just asked the tears in knee and shoulder joints, but Linda also, I don't know if it's the same Linda, can Tecfidera cause squamous cell skin cancer? I don't know if it's Tecfidera that causes it. There seems to be a slightly higher incidence of it. It's not significantly higher than in the general population. It may be that in specific individuals, you may see that it's a little higher. Barbara has her hand up. Barbara, could you unmute yourself and go ahead and ask your question?
Hello, can you hear me?
Hi. Yep.
Oh, okay. I wasn't sure how it was going to work. Uh, I was diagnosed with MS about 23 years ago, and I have had allergic rhinitis almost as long. Medications used to work, but now I have been coughing for the last 3 years. I saw an article that said something about MS and cough, but they attach everything to MS these days. Um, but didn't know if there was a connection. The medications that I'm taking are not working. So I have an allergist. I think he is really practicing on me. But in the meantime, I have been runny nose and coughing for on and off for 3 years, and it's really getting old.
Oh, I'm so sorry that's happening. Um, I can relate to that. After I had my first bout of COVID in 2020, um, I actually had it before we even locked down the country. I had what you're describing, the constant cough and the phlegm in the back of my throat all the time, and runny nose. It interfered with sleep. I'd get up in the morning and I'd be hacking for hours. That was a side effect of the COVID. And I'm wondering if maybe you had COVID at the start of this, maybe even a minor case of it that you didn't even know was COVID. And that may have triggered it. And again, um, you might want to have a talk with your allergist or your neurologist about maybe trying a few monthly infusions of IVIG to kind of knock that down. Now, intravenous immunoglobulin IVIG is it is a blood component. It's not blood. What they do is they take the antibodies, they filter the antibodies out of the blood of about 150 blood donors for every dose of IVIG that you get. So you're getting other people's antibodies to help you fight what's going on within you. And I did find after I started on IVIG that those long COVID symptoms, along with the allergic rhinitis, disappeared. It took 2 or 3 months, but it got them under control over that period of time.
I'm at the point where I will try just about everything. I did have COVID about 2 years ago, but I had been having problems with the allergic rhinitis before, but it was not continuous. So maybe that was the COVID kind of triggered some changed some things too. I will try that. Thank you.
You're welcome. It could have kicked things into high gear for you.
Absolutely. I'm sure it did.
Okay, thank you for asking that question. Judy says, my insurance denied Rituxan, so I'm getting Truxima infusion since that's covered. Is this the same kind of drug? It is. Truxima is another generic it's another B cell depleter that is a little bit less costly than any of the B cell depleters that are on the market, but no less effective. So again, that's something that is quite effective and helpful. Angie from Facebook asks, what can I take for pain? Pain, it depends on what the pain is from. If it's pain that's from activity, or if it's pain that's from bruising, then things like Tylenol or ibuprofen may be helpful. We now know that narcotic pain relief is really not effective against any of the pain syndromes that are typical to MS. It is for acute pain, such as you would have from a surgery or a severe injury, but it should not be continued. And I know that there are people listening to my voice that have been on narcotic pain medications for years. So I would just rely on the over-the-counter Tylenol. Okay. Let's see. I just want to make sure I haven't missed anything from Facebook. Okay. I did miss Barbara's question here in the chat, but she unmuted and asked her question. Mark from Facebook asks, is Ocrevus the most effective B-cell therapy? It's no more effective than Rituxan or Truxima or Kesimpta or Briumvi. They're all pretty much the same efficacy. Ocrevus is by far the most costly of all of the B-cell therapies. And I don't see any more questions. We are basically at the top of the hour as well. So thank you all for bringing your questions and for your attentiveness. If you're with us on Zoom, please stay on the line for just a moment after the recording ends for a quick question, quick survey on what you would like to see in upcoming programs so that we are giving you what you feel that you need at any given point in time. Our next webinar is going to be next Tuesday, April 9th at 4:30 in the afternoon, and it will be Dr. Thrower doing his question and answer, Ask the MS Expert. And so please join us for that. Thank you again so much, and we'll see you around. Take care. Bye-bye.